It actually gives me really great pleasure to introduce Professor Jo Patterson to you this evening. So Jo completed her undergraduate studies in City University and was immediately appointed afterwards as a speech and language therapist in Chichester, followed by a stint in Derby. I think that's right, isn't it, Jo?
Yeah,
and then a year in New Zealand, followed by an appointment to an NIHR research fellowship in Newcastle, which is where she completed her PhD. And that's actually the first real meeting I had with Jo, was actually acting as her external examiner in that PhD. And it shocked me to find out today that that was back in 2010. But what was clear at that point in time, that the quality of the work that and the way that she was thinking was really evident at that time. So following that, completing that, she was then appointed as a senior lecturer in Newcastle until we persuaded her to move south, or a little bit further south again, to a current post as the first professor of head and neck speech and language therapy in the UK, as far as we're aware. So Jo's actually a recognised international leader in her field. She's got more than 60 publications, more than £4 million worth of career research funding. She's got too many national and international presentations to actually count. She's a really gifted and enthusiastic mentor, supervising numerous PhD students and fellows, including, and this shows the breadth of her reputation, if you like, that recently recruiting Heather Starmer from Stanford to complete her PhD in Liverpool, which is a great measure of Jo's standing in her field. So she's got a vast, in addition to this, she's got a vast array of national and international leadership roles, and there's no doubt that she's one of the most gifted and influential academic speech and language therapists of a generation, and we're extremely lucky to have her in Liverpool. And I personally was extremely lucky to have her as a colleague and friend. So Jo's going to talk to us tonight about the impact of speech and language therapy in head and neck surgery in its broadest sense. And just a few housekeeping rules before we go. The chat is open, and Julie will be keeping an eye on the chat. And if anybody wants to stick their hands up at any point in time, particularly afterwards, we'll open questions after the talk is finished. So Jo, if you're ready, and if there are no questions at this point from anybody, just share your screen and you start when you're ready.
Terry, first of all, thank you for those very kind words. I feel myself slightly blushing. I hadn't expected such a long way back. But really, you are the reason I moved to Liverpool, because you've championed a senior clinical academic role in speech and language therapy. And those of you who are speech and language therapists on the call will know how rare those sorts of posts are. And you continue to champion speech and language therapy, and that's evident by some more opportunities in our expanding speech and language therapy workforce, which we'll be advertising new posts for in the near future. So if you're interested in coming and joining us, then please keep your eye out for those posts. So this evening, I'm delighted to give this webinar on a subject that really has been close to my heart, and I've been working on for many years in looking at functional outcomes in head and neck cancer. I know there's numerous expertise in the virtual room, so do please feel free to comment, pose questions, or generally heckle. I will be pausing at various points throughout the presentation just to pick up anything that's cropped up along the way. But if I go back to a time when I first became interested in functional outcomes in head and neck, it will have been at the turn of the millennia, when I had a patient referred to me following a new treatment that was being termed organ preservation, and of course we now know this as chemoradiotherapy. And here is a videofluoroscopy of that gentleman who I first met probably about 3 months after he'd completed his treatment. And on this video fluoroscopy, he was persistently aspirating. He had a very immobile tongue, so even speech was difficult. And he had no idea that this was a potential consequence of this treatment. He'd had a large base of tongue tumour and ended up being permanently dependent on a feeding tube forevermore. But then a few months later, another patient was referred to me, again with a large base of tongue tumour, opted for chemoradiotherapy. And here's his video fluoroscopy, which shows them quite quickly downing a large volume of barium liquid. And this for him was a good treatment outcome. It enabled him to get back down to the social club and be with his pals. And so it really demonstrated a wide variation in outcome. And this was really quite perplexing because at the time there was no research into this new treatment, had no idea what the outlook might be for patients. And subsequent to that, we now have different treatment options, and how do they compare? Would they be better? Would they give better outcomes? And ultimately, how can we improve things for our patients? So this really was an odyssey of my own. First, to acknowledge this work has been as a result of lots and lots of collaborations with people both at local, regional and international levels. And I've been fortunate enough to work with many really skilled individuals in their own right. But I just want to highlight Val Bryant here, who I've worked with for a number of years now as a patient representative. And she's really helped to make sure that this research is very entrenched in what the patient's needs and thoughts are. And then subsequent to that, since joining Liverpool, I've had the pleasure of working alongside the Head and Neck Patient Research Forum. And this is a group that I've admired for many years at a distance, because they've produced so many really useful resources for patients to inform them about what the likely treatment outcome may be, and really it being entrenched in that patient's voice. So this slide is from my PhD. It's an old slide now, and it was the beginning of my work in 2005, which was really looking at patient priorities and what were their top concerns both before and after treatment. And it showed quite early on that swallowing was actually their top priority, both at pre-treatment and at subsequent post-treatment time points, followed only by dry mouth and saliva. And perhaps that's not surprising, because food and drink has a complex meaning to us. It's not purely about nutrition and staying alive. It's often about coming together for celebrations such as birthdays, and perhaps we need to just think for a moment about how important Christmas dinner was for us this year, thinking about being apart from loved ones, from people we would normally be spending time with. But it's a source of comfort, connection, and of course pleasure. And therefore, when it's taken away from us, then life can be that much greyer. And when I look at some of the photographs that I've taken along the way, just thinking about how patients may then eat and drink thereafter. This is an individual who incrementally was increasing the number of porridge oats that he had in his porridge per day to try and improve his swallowing. But more often he was eating porridge day in, day out. This dish was lovingly prepared by the wife of the patient, who was keen that he should still try and enjoy his food, dutifully pureeing different textures up to give him the colour and a different taste profile in his meals. And then we have this gentleman who was eating Fray Bentos stewing steak every night, and we can see just the amount of gravy that he needed in order to be able to get this food texture down was habitual. And then this gentleman here was just really having tomato soup every day, heated up in the microwave, and he'd even opted just to eat that directly from this measuring jug, no longer really being bothered to put it in a bowl, and this is what he was having day in, day out. Even for those individuals that end up with a more textured diet, then frequently they're having to add a lot of sauce to it, or have it alongside a large drink to enable them to get it down. These are quotations directly taken from patients about their reflections on eating and drinking problems. This guy here was talking about things going down the wrong way, being unable to breathe and thinking he was going to pass out, and how scary that was if you've got a profound swallowing difficulty. This person is talking about how they just don't enjoy eating at all. It's just not a pleasurable experience. And the stigma and embarrassment of sitting at a table with others coughing up food. And of course, this leads to curtailed social life, people no longer going out and feeling very isolated and strongly aligned to depression. And also the lack of pleasure when you're just eating the same stuff day in, day out. And that can impact on families too, creating a lot of tension in relationships and dynamics in the family situation. So we know that swallowing is a really important issue, and that's not to say there aren't other functions that are equally as important to head and neck cancer patients. I'm thinking about communication and alterations to breathing too, but my work is more or less focused on eating and drinking outcomes, so this is what I'm going to share with you this evening. So how do we collect thinking about outcomes regarding swallowing in order to be able to better inform patients about what their potential might be? Well, this work was an international collaboration that was conducted a couple of years ago, where we were looking at the different swallowing outcome measures that could be used to collect this information. And this identified that there were already 27 different types of measurement. And so it's no wonder, with everybody using slightly different tools, it's really quite hard to pull that information together and get any sort of meta-analysis. So I'm going to drill down in a bit more detail about which measures to collect for swallowing outcomes. And I've tried to compartmentalize these for ease of thinking into these three distinct categories, including the patient report, typically by questionnaires, clinical measures, and more objective tests, whilst recognising that there are also surrogate measures that are equally important, such as feeding tube or pneumonia. But these are very much surrogate measures. They're not really telling us much about the swallowing function themselves. So I'm going to begin with to look at the patient report of swallowing. And I'm sure many of you will be familiar with this questionnaire, which is the MD Anderson Dysphagia Inventory. And this questionnaire has been around for just over 20 years now. And so there's a large volume of published work looking at the MDADI. It has 20 questions. It originated in the USA, and it has 3 subsections covering functional, physical, and emotional. Before we move on, though, I want us to consider how change occurs, or how we might think about change as measured on these patient-reported outcome measures, because they behave differently from physical changes or measures of something like blood pressure, for instance. So the mechanisms of change are sometimes referred to as a response shift. And that might occur because there's been some kind of change in health status. So if somebody's swallowing actually improves, then we are likely to see that on a PROM. However, antecedents are important as well, and I'm thinking in terms of how optimistic an individual might be, whether they have substantial depression. These things are likely to influence how somebody fills out a questionnaire. And for some, there might be some degree of reconceptualization. We may see that in something like cancer because people have undergone treatment for a life-threatening disease, and so they may be able to trade off the consequences and reconceptualize swallowing as perhaps an acceptable trade-off for cure. Whereas others may develop more effective coping mechanisms, and you'll see this reflected in the patient-reported outcome measure too. And I'm going to come back to that later on in this presentation. So back to the NDADI then. What we do know about this questionnaire is that it's responsive over time. It differentiates between treatments as we might expect. And it has a clinically significant difference that has been calculated in work conducted by Kate Hutchison at the MD Anderson, and that's calculated as being between 8 and 10 points. So an 8 to 10 point difference is likely to register as a patient perceived change. It's not licensed, and therefore we can use it quite freely for research and clinical purposes. However, there are a couple of downsides to this questionnaire. It is a bit tricky to use if somebody is tube fed or nil by mouth, or they're an inpatient, or in fact, if they have no dysphagia at all, some of the questions make it a bit difficult for patients to interpret. And perhaps it being a product of being developed over 20 years ago, the psychometrics of the reliability and the validity of this questionnaire didn't undergo full testing at that time. So since then, we have done some work on the psychometric properties of the NDADI as a preliminary study. And this, in effect, was looking at doing some fancy factor analysis on a large database of NDADI questionnaires. Really, at this point, we were looking to see whether there were any redundant questions that were being asked, to see if we could shorten the questionnaire and to see whether there were any overlap between those questions. And sure enough, this work did find that there was some redundancies, and so we were able to reduce the questionnaire to just these 5 key questions, and those quite neatly mapped onto the 3 subsections of the questionnaire. But this definitely needs a little bit more validity testing before we can roll it out as a shortened version of the mini NDADI. Okay, back to my chart then, and I'm going to move on to looking at clinical outcome measures of swallowing, and how would we collect those and what would we look for in an ideal test. So for me, these measures are something that I'd be conducting alongside the patient. So in many ways, it's good that they're cheap for a start, quick to do, repeatable, and perhaps importantly, could be administered by a non-specialist, because speech and language therapy is still relatively rare and exotic, and also this is a multidisciplinary team concern too. So sometimes having measures that can be conducted by other professionals is a handy thing. So one of the outcome measures that I have routinely used, and I've got a lot of experience with using, is this diet texture scale as part of performance status scales. And restrictions in diet texture, we know, is a really important issue to patients. It's closely aligned to quality of life outcomes. So this scale moves from 0 right up to 100, according to the different textures that can be eaten by the patient, right up into 100, which is a full diet without requiring any drink alongside you. So I couldn't not mention the 100 mils timed water swallow test, which again I set out as part of my PhD to look at this as a quick clinical measure of overall swallowing performance for patients. And the equipment again is very cheap and easily accessible. All you need is some kind of measuring device to measure out 100 mils of water and a timepiece. And then you give the patient the instructions: can you drink this as quickly as possible without making yourself uncomfortable and without trying to talk during the assessment, because I've had a number of patients attempting to do that. At the same time, the assessor places their hands on the front of the neck and counts the number of swallows and times how long it takes for them to drink 100 mils, stopping the stopwatch on the final swallow. And this again is a measure of overall swallowing performance rather than physiology. And from this test, we can calculate two metrics. The first one being swallow volume, which is the number of swallows divided by the mils swallowed, and swallow capacity, which is the time to swallow divided by mils swallowed. And these two measures are actually very closely aligned. So in practice, I tend to just stick with summarising this using swallow capacity scores. Janan Altamini has recently conducted some work drilling down, again looking at clinical significance in this test, noting that a change of 5 mils per second on swallow capacity is likely to be a change that is going to be noticed by patients. And I think that's going to be very important information for the future. In terms of interpreting this test, there are norms out there. And one thing to be aware of is that this test has gender differences. So generally speaking, adult males will be able to down 100 mils in approximately 4 to 5 seconds, whereas for females they'll take a bit longer, and it's not surprising for them to be somewhere between 7 and 8 seconds. But there are other things that will influence this test. So the degree of pain that somebody is in, and certainly we've recorded this following radiotherapy, that will profoundly affect the time it takes to drink this amount of water. Confidence with swallowing and dexterity. Certainly if you've got somebody with quite a substantial tremor, then this will affect the outcome. But all of these things are important considerations for swallowing. More recently, as part of the speech and language therapy community working on Pathos, which is a trial I'll come on to later on, there's been some work done to establish the reliability of conducting this test remotely via video call, and the potential for patients to be taught how to do this test on themselves. And that brings in the possibility of self-monitoring. And this is really pertinent to the current situation, isn't it, when patients are, we may not be inviting them into hospital for these tests. So going back to my diagram, I'm going to now cover more objective tests, although these do rely on judgments, and think about the instrumental tests that are available to us. And I think the mainstay for both clinical and research purposes is videofluoroscopy or fibre optic endoscopic evaluation of swallowing. And with these tests, there comes a number of different scales. And again, I've had experience of these both clinically and research to see how well they perform. But generally speaking, now we're looking at using the penetration aspiration scale, the MBS-IMP scale for videofluoroscopy, and the digest VF and V scale. So I'm just going to pause there for a moment, just in case there are any comments or immediate sort of questions that you want me to address before moving on to the next section.
So I can't see any hands up at the minute.
I'm happy to move on. Yeah. Hang
on just a sec. Julie, is there anything in the chat at all?
Yeah. A question from Lucy in the chat from Lucy Co. Is this a tool, so the tool that you've just been talking about, is it a tool and a test that can be done by non-specialists? Which I think really you started to answer later by saying about the potential of patients using this, but could you expand a little bit more, please, Jo?
Yeah, definitely. I think those clinical tests, both the diet texture scale and the water swallow test, we've had a long history of actually research nurses using those scales to collect that data, and actually with a tiny bit of training, it's possible to maintain reliability and validity of those. Obviously, for the instrumental tests, that's a different matter. That will require more specialist training, and it falls under the remit of speech and language therapy. But obviously, for the MD Anderson Dysphagia questionnaire, again, could be administered by anyone. So really quite versatile outcome measures for us. Okay, shall I move on and go to the next section?
Yeah.
Okay, all right, so the next bit is really to look at the different types of treatment and how those swallowing outcomes compare. So this is again from my PhD work, which was reflecting back on that videofluoroscopy that I first showed you. It was really trying to collect swallowing outcome measures for patients that have been treated by three-dimensional chemoradiotherapy. And this is just one of the measures I use using the MD Anderson Dysphagia inventory. And we can see here in the simple line graph that there was a substantial drop from pre to post-treatment at 3 months and very little change from 3 to 12 months. Subsequent to that, Justin Rowe from the Marsden then collected similar outcome measures for parotid-sparing IMRT treatments. And we pulled our data to look at whether there were any sort of differences between the two. The first thing to notice that there was actually quite a substantial difference between our two cohorts at baseline. Justin's cohort was reporting much better swallowing, but with a steeper fall at 3 months and some improvement between 3 and 12 months. But we could find no significant differences between these two groups, whilst recognising it wasn't powered to look at differences. And then more recently, I have done some work with Susie Scott, who is an ENT doctor from Denmark, and she has been looking at comparing IMRT with transoral robotic surgical outcomes. And we can see from this work, she is reporting some really, really good outcomes using the MDADI. So clearly, there's a big difference going on at that particular centre. Okay, but that isn't the end of the story with radiotherapy, because it is something that can go on to produce some quite severe side effects in the long term. And evidence is emerging around late effects radiotherapy, and this can affect swallowing significantly. And that's thought to be due to an unrelenting pattern of fibrosis with progressive accumulation of collagen, altered microvasculature, and overall leading to a loss of elasticity. And that is really important for swallowing function and has a number of consequences. So data is emerging that just under half of those that are admitted with aspiration pneumonia following late effects are then transferred to intensive care. That just under a fifth of non-cancer related deaths in head and neck cancer could be attributed to aspiration pneumonia. It will involve and require thinking around rehabilitation and being quite creative with interventions, and has consequences such as antibiotics and hospital admissions. So really, it's a really difficult problem to deal with. This was a 6-year follow-up study from my initial PhD cohort, and these are the MD Anderson Dysphagia inventory outcomes. And from here, just building on that 12-month outcome, there's very little change from 12 months to 6 years after this three-dimensional chemoradiotherapy. Of those patients that participated, because obviously there were people that dropped out over time, 13% of them were still dependent on a PEG, and 3 of them had gone on to have a laryngectomy because their voice box was no longer functioning. A third of them had persistent aspiration. just under a half had chest infections, and the risk of this was far greater in patients with aspiration. So it really calls into question, how do we deal with these individuals who may be on a trajectory of poor pulmonary health. This is an example of somebody who had oropharyngeal cancer treated by chemoradiotherapy about 6 years ago, and this is his fees. So he had persistent aspiration, and we can see here that was silent aspiration, so it didn't make him cough. And he was experiencing chest infections now and again, and we tried numerous different interventions with him. Ultimately, he was struggling to keep his weight up, and so ended up having a peg recited 6 years down the line. I'm going to move on to talk about minimally invasive surgery, and I know at Liverpool there has been a long history of treating and offering patients laser treatment for their cancer, and of course more recently there has been a movement towards transoral robotic surgery as a treatment option. This work has recently been conducted, led by Sarah Stevens, doing a systematic review looking at the early post-operative outcomes following minimally invasive surgery. And in a pooled analysis, she identified that approximately half of patients either had aspiration or penetration in the first week following surgery. Up to 8% of patients were readmitted. A quarter of them had moderate to severe dysphagia within the first month following surgery, and the predictors of this were pre-treatment swallowing function, tumour stage and tumour volume. And I guess this points towards getting a pre-treatment swallowing assessment to highlight those people that may be at risk. This data is taken now from Sunderland, where I used to work, when we were moving towards offering patients transoral laser surgery, and these are the MD Anderson dysphagia inventory outcomes for this treatment. In comparison to my previous cohort, we can see that these are scoring quite highly at baseline, dropping at 3 months with recovery by 12 months, with having some quite reasonable MDADI outcomes at 1 year. And again, I've plotted Susie Scott's transoral robotic surgical outcomes, and equally she is reporting some good outcomes. But these are from single centres on relatively small cohorts, and so that's why outcomes from the PATHOS trial will inform what's happening at a multi-centre level. And these are data that we've just looked at from PATHOS, which is recruiting patients who have had minimally invasive surgery. Just as a snapshot of this, if I just direct your eye to the safety bar here, we can see the majority of patients are actually not experiencing aspiration, have minimal amounts of penetration, although that can occur in this group, but in small amounts. The main issues are around the efficiency of swallowing, with 85% either having no problems with efficiency or mild issues. So I think in the event of time, I might just pass on the pause and come to that at the end, because now I want to try and think about how can we make things better for our patients. And I'm going to divide this up into looking at how we might prevent swallowing problems, swallowing prehabilitation and rehabilitation. So a number of years ago, I worked on a pilot randomized control trial, and this at the time was exploring the hypothesis that actually if you gave patients going for chemoradiotherapy a prophylactic gastrostomy, then they may stop eating and drinking earlier on into their treatment and leaving them at risk of developing kind of atrophy or fibrosis of that swallowing musculature, leading to poorer swallowing outcome measures, as opposed to those individuals that we opted to go for a reactive nasogastric tube. The upshot of this pilot was that it was almost impossible to randomise people to these two these two feeding tube options. That invariably people had quite fixed ideas about which feeding tube they wanted to go for. And looking at the swallowing data, there weren't any particular early signals that this was making a substantial difference, although there were lots of different factors that patients considered when electing which feeding tube was for them. So more recently, we've had a really explosion or high number of trials that use swallowing as a primary outcome measure. I'm going to talk more about pathos in a moment. DARS is randomizing people to dysphagia optimized radiotherapy versus standard IMRT, and we have the best of trial, which is comparing patients treated by IMRT versus minimally invasive surgery. So I'm going to deal with DARS first because they're now closed to recruitment and are in follow-up, and have recently put into the public domain their outcomes for the MD Anderson dysphagia inventory at 12 months. And on here at 12 months, we can see that there's a 7.4 difference in scores between those treated by dysphagia optimized IMRT versus standard IMRT. And I've just put my cohort outcomes here at 12 months so we can see the difference in those scores. There's further analysis to do on this data, and we are currently looking at the videofluoroscopy and other swallowing performance outcome measures. Okay, so moving on to pathos now, which is a collaboration between Liverpool and Cardiff, and it just gets bigger and bigger because there are now a number of international sites opening, as well as I think just under 30 UK sites. So this trial is looking at patients who have HPV positive disease treated with minimally invasive surgery, and the adjuvant treatment is risk stratified and de-escalated where appropriate, and we're looking at swallowing as a primary outcome measure alongside a panel of other measures too. And I think this really, the knock-on effect of having a trial like this has really engaged the speech and language therapy community in research, but also it will tell us a phenomenal amount about swallowing outcome measures for the future. And our outcomes are aligned across with DARS too, so we'll have a massive pool of data. We've currently got 600 videofluoroscopies that have been submitted for rating, and more information will be released on these findings as it comes. I need to also mention prophylactic swallowing exercises, because this has been a relatively contentious treatment, probably because of the state of the evidence base is kind of in equipoise still. And we can see that clearly. A Cochrane review was published some time back that seemed to suggest there wasn't much benefit from this intervention, but there were significant problems with adherence to these exercises, and also a plethora of outcome measures that have been used. This next systematic review using meta-analysis did demonstrate there was some positive effect from prophylactic swallowing exercises, and then a review published earlier on this year it didn't support those findings, and still said that it was really, again, in equipoise. So I look forward to the UK trial that will be opening hopefully soon, led by Rogini Govinda at UCL, and I know that she will be looking for sites to help her recruit to her study. Okay, finally, I am now going to talk about swallowing rehabilitation post-treatment. And I'm just going to mention this study that I conducted a few years ago now. And this was really trying to address not just the swallowing impairment at a physical level, but also to address the impact that it had on the way in which people responded to this, and the quality of life that was associated with living with dysphagia. And this was a combined treatment looking at using swallowing therapy alongside cognitive behavioural therapy. And for those of you who are familiar with cognitive behavioural therapy, it is about looking at cycles, thinking about how we think about things, affecting how we feel about things, and then it has consequences for our behaviour. So in terms of living with a swallowing problem, then it's not uncommon for some individuals to overestimate the danger associated with eating and drinking, thinking that they're going to choke and die. And if you had that thought, then obviously that would lead to panic and fear about eating and drinking, and that can then lead to avoidance of even trying anything out. And so once this cycle, once you've established the nuts and bolts of this cycle, it's then applying a CBT style therapy approach to working with swallowing difficulties alongside the impairment. So this is just one example of a formulation. So I am now just going to sum up, and on reflection and preparing this presentation, it really it highlights that progress has been made in improving swallowing outcomes over time. And I think perhaps with the integration of trials as well, that's really helped us harmonise our swallowing outcome measures. We're not quite there yet, but I think as a community, I think you'll find that we are probably trying to collect similar outcomes. But for the future, we will clearly have a lot more knowledge about the difference that modified cancer treatments can make. Prevention is always easier than treating the problem post-treatment. And so it's important that we look at our prehabilitation approaches too, whilst recognising that, that a lot of patients will still have swallowing problems, but thinking about how to holistically rehabilitate them, and moving ourselves forward in terms of patients being able to self-monitor themselves as well for any improvements or decline in function. So if you are interested in some of that work, then come and join us, come and join our team. We are lovely to work with and come and help us out in moving this agenda forward.